Napolitano. She will speak about the CPAP and different types of CPAP, what's the evidence behind.
Thank you. So we talked about mechanical ventilation first, and really switching gears now to CPAP. And to many people, CPAP is CPAP, right? To a lot of people, changes in the different type of CPAP really matters. I actually just did this talk with our neonatology group at the Children's Hospital of Philadelphia, because we're talking about a lot of different options. And we're a BPD center. There are 7 BPD centers in the United States that all kind of collaborate together, and we get all of the children that have really severe BPD. So on any given day, we have about 60 infants in our unit with severe BPD, and this is always a challenge when we're trying to keep them off the ventilator. So we talked about and kind of went back to basics on CPAP. And what does the literature show, which is a lot more than we really think it is, and it was interesting. As far as my disclosures go, for this talk, the ones that matter are Draeger obviously you can deliver CPAP, and they have some interfaces through their machines. But through Philips Respironics, we are trialing a couple of their newer masks and hopefully prongs that kind of get that age gap between about 6 months to 4 years of age where we really don't have good interfaces to use for our children to keep them on non-invasive support, as well as Neonatal, who is predominantly a Japanese company, but I have a patent pending in collaboration with them on a non-invasive mask that actually provides end-tidal CO2 capability within that mask. Not sure if that'll ever happen. We're still in the bench stages with some challenges, but we'll see if that happens. But as far as my disclosures, those are the only important ones for this talk. So the objectives for this is really, again, going back to what are our goals of nasal CPAP in our neonatal population, and what are we really trying to achieve? And continuing to ask ourselves that question, especially as days go by. Are we still achieving those goals with all of the challenges that we're continuing to have? There are a lot of different types of nasal CPAP out there. There are some similarities and some differences, and we have some bench studies that are actually quite old, but important to go back to when we're trying to compare these different types of CPAP to know what we really need. And then looking at the literature to really tell us when we're comparing them within our patients, what's working better than others. So starting with our goals, we really have 4 main goals. Our first 2, to me, are some of the most important. We need to maintain FRC, particularly in our premature population. We need to keep the lungs open. And there are some theories that we have really needing to maintain FRC in these babies, that it helps to spur some surfactant production sometimes. It just really gives them that chance, but we're really preventing the collapse. Preventing collapse of the alveoli, and then if they already are collapsed, we're trying to recruit them open. But what we're also doing while achieving those first 2 goals is we're also reducing work of breathing, and then we're stimulating breathing, therefore reducing apnea. And all of these goals really spiral on top of each other. If you get the first and you keep the first goal going, you'll achieve your second, and then you'll achieve your third, and you'll achieve your fourth. So it's one of the most important things, or simple things with nasal CPAP is our real goal that we need to make sure that we're maintaining is FRC. And if we keep that going and we keep asking ourselves that question as the days go on or the months go on that we're on CPAP support, we'll continue to help achieve the last 3. Safety and risks. And this is where we always go back to with non-invasive support. I'm not sure if this happens in your neonatal ICUs here, but when we keep our babies on support for a really long time, we get skin breakdown. We have challenges with the nasal interfaces, not only with the prongs, but also with masks. They sit there, their skin is so thin and so delicate, the tissue is so thin and so delicate that putting too much pressure changes your blood flow within the tissues, therefore it causes more breakdown. We're feeding them, we're not feeding them, they can't eat, so nutritional status plays a big role in whether or not they start to have skin breakdown. So that's the number 1. And the second is alarms. Looking at some of these different options that we'll see going forward is some have a lot of alarms to them, and some of them don't because we're not using the machines as they were intended, or they were never built with alarms. So you don't really know if you're achieving the CPAP level that you have set. And that's one of the things to keep in mind as well. There unfortunately is a lot of really limited data out there on a standardized approach to prevention and recognition as well to nasal CPAP. Some of the things that we have started doing in our hospital that we've been very successful with on all ages is we constantly rotate masks to proms, proms to masks, masks to proms. With every hands-on of nursing care, we're switching the interface out, so that constant rotation of the pressure points really has helped us, as well as using barrier devices. So there are really four levels of nasal CPAP. There's your continuous flow CPAP, and we'll go through each one of these more specifically. Bubble CPAP, which is really a form of continuous flow CPAP. However, there's a big group of people that think bubble CPAP is so much better than other types of CPAP. So we're really going to look at the literature of bubble CPAP by itself as its own type, even though it is a form of continuous flow. Variable flow, which is the CPAP machines, which I know you all, Ronnie had said you were starting to get here, and then the bi-level, which also is a mode that you can use through the CPAP machine. So we'll take a look at some of those and some of the literature. So starting with continuous flow CPAP, this is when a continuous flow is delivered through the ventilator to achieve a constant level of PEEP. Depending on your leak, that flow might change a little bit, but for the whole phase of your breath, inspiratory and expiration, you have the exact same flow level that's going through the circuit. Most commonly, this is delivered through a ventilator, so through the Dragers or whatever type of ventilator you have, the Avias, the servos. If you're in CPAP mode for any of those, this is a continuous flow mode of ventilation. Our positives for this is that it provides a consistent level of PEEP. You have some alarms you can still keep on there. You also have an electronic readout that tells you how much CPAP you're delivering according to how much you have set, so it's right there, you don't have to think about it. Some of the negatives, it provides this opposing flow during expiration. So you're breathing against more flow than you actually need to maintain the CPAP as you're breathing out, and this can provide some increase in work breathing on exhalation. And it's also delivered via short nasal proms. You can use nasopharyngeal proms in some places. We don't really use those in the U.S. much anymore, so there's a lot of breakdown happening that we couldn't see inside the airway and causing some trauma or nasal mask. So there aren't too many options for delivery of this. As the babies get older, we get into that range of kind of that 6-month to 2-year population. For those who are in the PICU, we don't really have good interfaces. They outgrow the neonatal interfaces. So we start to use some of the bigger pediatric ones. There's very, very small dark ones, sometimes going to a full face mask on these infants, but there's a lot of risks that come in with that. Bubble CPAP, again, this is a form of continuous flow CPAP. It provides a flow rate at the inspiratory limb, and then your expiratory limb is placed and submerged to a preset level in water. It's delivered predominantly via short nasal proms. However, since it's kind of come back into phase, and CareFusion started selling a device, there may be a different company that you all have here that sells a bubble CPAP device. They've also provided masks now, which helps you do that change back and forth. The negatives with this is there's no readout, there's no alarms whatsoever. You have no idea if what you have set via a water column is actually what you're getting, and you have no idea if you have a leak or if you're not achieving. This is kind of the picture of our old school CPAP, which a lot of people still use. You're setting your flow rate here with a blender going into your heated chamber that goes through and essentially this continuous flow that goes past the nares that the infant is breathing in and out against to the exhalation of your water column that's set. You have your centimeters of water pressure on the side. And oftentimes there's a readout that you can put on for an external manometer, but that's an additional piece, and a lot of the hospitals don't even use those. But no alarms. You can put some external alarm boxes on. Again, it's something else you have to get, not necessarily made for the system. So then we're starting to be engineers. And that's not our primary focus. And what we say in the U.S. is we're jerry-rigging things. We're adding things on, putting stuff that hasn't necessarily been made or been tested together. And then we have variable flow nasal CPAP, and this provides an adequate inspiratory flow to really maintain that stable airway pressure that you want, that peak, but then it also provides a redirection or a dump of flow during exhalation. So you're only getting the amount of flow that you need on exhalation to maintain your peak, but not additional. So in theory, it's reducing that work of breathing a bit. We'll take a look at a couple of the studies here to come that show that. And this is also delivered via short nasal prongs or a nasal mask. And this is proprietary brand through CareFusion. It's done on the CPAP machine, or they used to be called infant flow machines. Unfortunately, as the companies keep buying each other, they change the name of the device. So there's about 3 different names for this device that you can get. The downside to this is it's a proprietary circuit and proprietary flow adapter. And their prongs and their masks are really nice. They're actually longer. They're on individual joints, so if your nares aren't exactly the same distance apart, they move a little bit, and there's a flare at the end of them, which helps them seat inside the nair better, while the end of it never actually touches the septum. So these are really nice. I found really great success using this type of prong with the preterm, very low birth rate population. At my prior hospital, we were mostly preterm hospital, and we never really had much breakdown. We used this system only for all of our kids. Unfortunately, you can't translate those masks and prongs to any other system because the connections don't fit. This is just, there's 2 different types. There's 2 different companies that had the same type of system. They force merged, so now depending on which headgear that you buy, it's different. The one is the fluidic flip, and this is the older headgear. So the magic really happens with this machine in the flow generator that's on the face. So it's all right here. There's a system here where you have your ejector nodule with all of your flow going through, and then you have this tubing here that is a dump out, or an expiratory tube that goes out to atmosphere. That provides the expiratory dump. So that section here is amplified during inspiration. You see these jets of air going in and the flow, and nothing happening really on exhalation. Then on exhalation, you see this dump going across as the patient is breathing out. So they're only getting the flow that they need to maintain their CPAP level. You get that nice constant CPAP level. Vorticity Technology was the second company. Again, they're still all owned by the same company now. These are the masks and prongs that I prefer because they have this little bit of a flare at the end, and they see better. But still, all your magic happens in the generator, where everything is. It's not the machine. The machine is simply a flow driver, but it's all in the circuit. Unfortunately, the circuit and the flow generator only connect up to that. So, this little box amplified for inhalation and exhalation. You can see this is the part out to the baby when they're breathing out. You get this flow of air going through with the 2 jets. On exhalation, there's a spiral effect that then dumps the flow back out during exhalation. So the baby's only getting the flow that they need on inhalation. Again, these are proprietary. We've tried to connect them up to different machines, but you really have to have this beautiful, it's a periwinkle, pretty purple machine, but they're a little expensive. The next is bi-level CPAP, and this is a proprietary mode on the CareFusion CPAP machines that provides 2 levels of CPAP. So there's a level a lower and a high, and you alternate over a time cycle. It's essentially like APRB mode on CPAP if you're trying to do the same things, except that you also have that benefit of the dumping of flow during exhalation because it's all in the same mode and it's the same interfaces in the same machine. This provides the patient can breathe independently at each level of CPAP as you go up and down. It's provided by, again, the same mask and prongs. The benefit that people feel that there is to this is that you can have a bit of recruitment. If you need a higher level of CPAP to keep recruitment and keep your FiO2 down, you don't have to stay there constantly. And there's a little bit, if your pressure change is big enough, you may have also some CO2 changes that can go on with those 2 changes. This is a kind of a graphic, a rib cage graphic, as well as the airway graphics that you'll see. You have these 2 levels of CPAP that you're alternating through, and then each one of these little jagged marks is an additional breath. And you can see the CPAP level changes and the additional breaths. So the patient can breathe as much as they want at both levels, comfortably, with a lot less sedation. Again, very similar to APRB. So now we're looking at really what does the literature show. And there's a couple questions that we have as we're going through and taking a look at them. Is one device, one type of CPAP really superior over the other? And does one provide a higher level of support over the other? So also, Are there standard guidelines for use to achieve success with either one of these? We always kind of look for those. When you can standardize, it's always better. It's the only way you can really tell if one thing's working over the other. So bubble CPAP, we'll start there. Is this potentially a better practice? There's one hospital within the United States, Columbia, that has very low chronic lung disease rates. They have the lowest BPD chronic lung disease rates in the nation. They're a premature birthing center. They have a lot of micro-preemies, very low birth weight infants. They have a lot of them, and they do a very good job with lung disease. And their brains are relatively good too, and we think about brain bleeds. So everybody's been trying to replicate what they do in the U.S. There's been a couple studies that compare some, looking at these, but none of them, they show similar reductions in ventilator length of stay and BPD rates, but they never really quite get the reductions that Columbia has. The important thing that we really have to think about is it really bubble CPAP that did this just because they use bubble CPAP? Is that what really made the difference? Or is it an entire algorithm of care of which they use that surrounds when to use CPAP, when to re-intubate, and everything else that comes into the complex care of a neonatal patient? One thing, there's not one magic bullet that's going to do it and make the changes. So there's a lot of other publications that also looked at various primary outcomes, but didn't really see the big change that Columbia has seen. So let's take a look at a couple of these studies. This one that was done, published in 2009 in the Journal of Pediatrics, was a QI intervention, and the primary goal was to reduce BPD and improve their other pulmonary outcomes, such as pneumothoraces, and their very low birth weight population with the implementation of bubble CPAP. So the only thing they changed in the care was they now use bubble CPAP from whatever their prior method was. We don't know what that was. We have no idea what type of CPAP they used prior. If it was the same type, it was very different kinds. They didn't really disclose that in the publication. And they compared outcomes from pre and post implementation. So it was really a quality improvement intervention, not structured as a research project, didn't control for a lot of the things that we really want to see controlled for in a main study. And they found that they did have a reduction in the use of mechanical ventilation overall, but they saw no difference in the pulmonary outcomes, including BPD. And they also saw an increase in the rates of ROP in stages 1 and 2, which is increased negative side effect that they did see there. The questions that we have within the study is we have no idea what their use of mechanical ventilation was prior. They were potentially just overusing it and not extubating appropriately. And they used 4 to 6 centimeters of bubble, but they didn't note the liter flow. And that'll be important as we go forward and see some of the bench studies with bubble CPAP. So we're not exactly sure how they used it at all. Next study that was published in 2010 was a bench study that really looked at the accuracy of delivery of bubble CPAP. They looked at the effect of vigorous bubbling with the change in flow rate and how that also changed the effect of the pressure that was delivered. They did submerged depth of 5 centimeters of water pressure. They kept that constant, and then they changed their flow rates over 16 different rates from 2 to 20 to see what the changes were. They saw a direct correlation with an increase in pressure in the proms with an increase in flow. So as you change your flow rate, you're going to get more CPAP, even though you haven't changed your submersion depth past 5 centimeters of water pressure. So it's an interesting development. And on average, their intraprom pressure was 6.2 at 2 liters per minute up to 8.8 at 20 liters per minute. So even when they started at 2 liters per minute with a submersion depth of 5, they didn't get 5, they were getting 6.2. So there's an overshoot there with bubble CPAP that without any readouts and without any alarms, you don't know that you're delivering more PEEP than what you had originally intended. 5 versus 6.2, is it really that big of a deal? Is it clinically important? It may or it may not be, and that's one of the things to think about with a lot of these studies. Just because it's significantly different from a statistical method, is it really clinically important? If you have a 24, 25 weeker, it might be clinically important. But if you have someone who is now post-gestational age 44 weeks, it's probably not that important. So it really depends patient by patient. So our next study looking at accuracy of delivery was another bench study that also looked at the intended intraprom pressure, proximal airway pressure, and distal airway pressures, comparing ventilator-driven CPAP versus bubble CPAP. So now we're comparing the two different types that are all a continuous flow. The measurements were repeated at 5 different flow rates, 4, 6, 8, 10, and 12, and at 3 different CPAP levels. They looked at 4, 6, and 8 at all those different flow measurements. And under the 3-pronged conditions of no leak, small leak, or large leak. And this was published in 2007 in Pediatric Research Journal. And what they saw was that the ventilator-driven CPAP, first the bubble, showed a consistent measure of intended pressure at all the different pressure levels that they measured it at 3 different locations during all conditions of flow and all conditions of a leak. Very consistent CPAP. When we looked at bubble, there was an overshoot of pressure with all flow rates at all leak levels. And an overshoot of pressure was greater as your flow rates increased. So real inconsistency with bubble CPAP compared to ventilator-driven CPAP. So it starts to make you think, when you're comparing the 2 different types, are we really comparing in studies apples to oranges? So now looking at the effect of gas exchange. There was a randomized crossover study that had been done with 26 infants. I apologize, I forgot to put which study this was at the bottom. And they used 6 centimeters of water pressure as their CPAP at a slow bubbling at 3 liters per minute, and then they did a fast bubbling at 6 liters per minute. And they monitored the oxygen saturation through SpO2, also through transcutaneous, and then their heart rate, respiratory rate after 30 minutes on each of the settings. And the reason for this study is theoretically some people start to think that the more vigorous the bubbling, it actually might improve your CO2 changes as well. So what they saw is that there was no evidence between the 3 liters and the 6 liters of gas exchange at all in these infants. So the CO2 levels pretty much stayed constant. Another study comparing continuous versus variable flow. This was a crossover study that was published in 2011 in the Journal of Pediatrics. They looked at, so we're using, whenever we say variable flow, it's a CPAP machine on the CPAP where it has that offloading or the dump out of the expiratory flow. And they looked at 24 infants on CPAP. Each infant had both types of CPAP, and then they compared their parameters at 4 different levels. And they looked at tidal volume, esophageal pressure measures, and respiratory inductive plethysmography as well, looking at work of breathing. And what they saw was that the work of breathing decreased on all CPAP levels and lung compliance within the variable flow device, so that offload of the work of breathing was significant on these infants. And they actually saw that changes was a 13% to 29% reduction in work of breathing. So that offload of the work of breathing does seem to really matter. At least 24 infants did. Taking a look, another study at the bubble CPAP versus ventilator-driven CPAP. This was again a crossover comparison of what was actual versus what was set in 12 infants. They looked at 3 increasing flow rates on 4 and 6 centimeters of water pressure, and they compared the measurements were at a constant flow setting for 2, 3, 4, 5, and 7 centimeters of water pressure. And what they saw was that the intraprong pressures for bubble CPAP were flow dependent, just like we saw in some of the past studies and the bench studies. As the flow rate was increased, the average intraprong pressure changed as the flow went up was 1.3 centimeters of water pressure, higher than set, pretty constant. And we saw that in one of the last bench studies as well, that it was up by about 1.3. An additional study that was published in Journal of Neonatology in 2011 by Sherry Courtney, who does a ton of ventilation and non-invasive ventilation research, which was a randomized crossover trial with 18 premature infants, and they looked at work of breathing and gas exchange at various different flow rates and pressure rates, or I'm sorry, a constant flow rate at various different pressure rates. And they also looked at intrapleural pressures, tidal volume, minute ventilation, heart rate, respiratory rate, as well as lung compliance, and our CO2 and SpO2 changes. What they didn't say in this study, however, is if they measured actual CPAP or delivered or set CPAP. So we don't know if it was actual or set when we're looking at these at the comparisons here. They did see that the transcutaneous oxygen was higher in bubble CPAP, and the work of breathing and the CO2 were not significantly different between them. Another study looking at the comparison between bubble CPAP and the variable flow CPAP, the CPAP machines. This was another crossover study with 18 infants that looked at work of breathing and asynchrony. And they looked at tidal volume, esophageal pressures on various different CPAP settings. They utilized a 5 to 7 liter per minute flow on this. And they looked at set levels of CPAP, not actual delivered levels of CPAP. So keep that in mind too with these results. They saw a change in respiratory rate and work of breathing was greater with the bubble CPAP than with the variable flow. And they predicted that there was potentially a greater failure rate over time with bubble CPAP because of the increase in work of breathing. Keeping in mind this was a prediction that they put into their paper. There was no statistical analysis that was done for this. It wasn't powered to make this type of prediction. But it's an interesting look for research for the future. If over time there's a greater failure rate. Again, a study comparing bubble CPAP to variable flow CPAP. And this primary outcome was extubation success over 24 hours. They also looked at the secondary outcomes of extubation success over 7 days and the duration of CPAP support. They also looked at chronic lung disease and any other complications of prematurity, such as our neurological outcomes. These infants were actually ventilated for, the duration of CPAP was 50% shorter on the bubble CPAP than with the variable flow. And there was no difference in extubation success, chronic lung disease, or complications of prematurity for those that were ventilated for greater than 14 days. If we look at those who were ventilated for less than or equal to 14 days prior to going to CPAP, there was a significantly higher success rate. And they used a CPAP level of 6 for extubation for both. However, again, it was set CPAP, not actual delivered CPAP that they had measured with that. And the bubble was a set 6 liters of flow for that study. An additional randomized comparison between CPAP and the bi-level. So this is 2 different levels of CPAP on the CPAP machine, or the CPAP mode. And they looked at a comparison between that bi-level and infants on traditional nasal CPAP who were 28 to 34 weeks in respiratory distress. The outcome measures they looked at were an inflammatory response, length of ventilation, their oxygen needs, as well as need for intubation, and if any airway leak occurred from thoraces, whatnot. And what they saw was that with the traditional CPAP group compared to the bi-level group, and I apologize, this was all you saw on the CPAP machine. So it was a variable flow CPAP versus a variable flow bi-level CPAP. So it was the same interfaces, the same types of CPAP comparisons. And they saw that the traditional CPAP group was associated with a higher time on CPAP, a longer O2 dependency, as well as they were discharged later than those with the bi-level group. So there did appear to be a benefit for the use of the bi-level CPAP. But there was no other difference in any of the other outcomes that they had looked at. And they used a CPAP of 6 centimeters of water pressure was their standard for extubation there. And their vent length of stay difference was 6.2 days versus 3.8 days, so it was pretty large. And the discharge difference was actually 1 week difference, depending on your length of time. And in APU, does that really matter clinically or not? I'm not sure. So in summary, we've come to the conclusion there really isn't that big of a difference between CPAP. CPAP is CPAP is CPAP, as long as you're comparing the same thing. If you're comparing what is delivered with what is delivered, as we saw in many of the studies, that when you're looking at bubble CPAP, you're oftentimes getting more than what you bargained for, than what you were setting for. And about 1 centimeter of water pressure, which is interesting, it's significantly higher. And then we also, none of these studies looked at any of the safety concerns for use. So being on longer could have additional concerns, but nobody looked at the methods of securing the babies on. Oftentimes when we see people using bubble CPAP, they secure Velcro to the face and they Velcro the interface to the baby. So what are the outcomes with that? And really we haven't looked at any long-term neurodevelopmental outcomes of either one of those. And as we go through, it's one of the things that Brian had mentioned within his last study that we don't have with a lot of our advanced modes. We don't really have that either with CPAP. And as we're going forward, really taking a look not just at their IDH or PBL, but also what's their Bailey II score. It's really great if we can see that we spent less time on a ventilator and we have less BPD or we have less mortality overall. But for those that are still living, what's the morbidity? And that's what our parents ask us all the time. They want to know if their baby is going to be normal. And until we start looking at some of these longer term outcomes, we're not really going to know that. That's it for CPAP. Any questions? Yes?
Discuss about last point. If I use CPAP for 1 month, I suspect and there is a side effect.
That's a good question. If you're on CPAP for a month, what would the side effects be? And we don't really know. We haven't looked at any of these long-term. All of these studies were crossover trials for the majority of them. They're on for a couple hours and they switch over. Oxygen toxicity is huge. Again, none of us looked at this in any of these studies. However, if you're on CPAP with a higher oxygen level, then that's a problem. The one quality improvement study that we saw that started bubble CPAP in their unit, they saw a lower incidence of mechanical ventilation, but they did see an increase in RRT because their oxygen levels were higher. So that's one of the things that we're going to take a look at going forward with some of our cases. But if you're not meeting your goals of living, being on CPAP, if you can't tolerate being handled, if you're needing higher oxygen levels to be touched, and if you're not growing, if you're not able to eat, if you're not doing these other things that are really causing more harm being on CPAP than being on a ventilator. So that's a very good question. We don't really know the answer to. We just have a theory of what it should be when we add all the different studies. That's good research for the future.
Thank you very much. Well, as regards to what I thought CPAP, actually when one and I started in Colombia, they have nice results when any board came to the report that in Washington, there they had the same results. The idea is that they deepen their public CPAP and they use it. Colombia contains an easing scale and no contraindications, so it will be good. And they said that this might be something like something like high frequency. Now, I want to ask you about there is also a public ventilator. So someone from California, I don't know if you know, he said, if we measure pressure by centimeter, and if one would have a peak of CPAP by centimeter, why I don't have another column that will reduce the IP, then I will play with them, and the only thing I need will be something that low cost, only a humidifier and oxygen blender and respiratory design. Now we have for Africa a very cheap ventilator which is called water public ventilator.
So two points there. One, Columbia and in Washington, D.C. using bubble CPAP, and they believe that that's the best way to go. CPAP in general, most people feel is a better way to go as long as you're spontaneous breathing. The question here is, does it need to be bubble? And Columbia feels so. They've done a great job with that. But no one's been able to replicate what they do there. Not even Washington, D.C. They don't have the same outcome rates. So you wonder if all we did was change to bubble CPAP and nothing else, then why don't we have the same outcome rates? And as you'll remember from being in Columbia, they have a very strict algorithm of care. When you intubate, when you extubate, and all the other, how much and when they load with caffeine. So there's more to getting those lower rates that they have than just the use of bubble CPAP. And if you understand how your CPAP works, also when we're comparing what Columbia does with some other levels, Columbia may set their CPAP at 6, but they're really getting 7.3 if we looked at all the bench studies. So we're looking at studies that compare that other ventilator-driven or even the variable flow, with buccal, if we're not comparing delivered versus delivered CPAP levels, we're not giving an equal comparison because you're getting more CPAP because you don't have the readout from the alarm. As a note to the bubble-driven ventilator, when you're in lower income areas that doesn't have the ability to purchase the machines that we have or electricity, these are wonderful options to have, but I worry about the safety. There's no alarms. And individuals using them that don't have training. So I do a lot of work in Haiti. I've been working over there over 2 to 3 times a year and have been for about 5 years working with the same hospital. And they don't have critical care training. The doctors don't have any critical care training. The nurses don't have any critical care training. And they're maintaining these systems, so there's no alarms to alert them that they're out of range. Don't have a great understanding of what out of range means and why they need to worry. So there's concerns. Are they doing more harm than good by not having some of the advanced systems when they're not really sure how to use those either? But one thing to note too, with the change in gas flow, is that Rob DeBlasi, who was here with you all a couple of years ago, is trying to do some research on that, and where he actually found the change in CO2 was by changing the elbow on the inserting into the water pump. So there's more research being done on that specifically.
Dr. Natalie, thanks for your elite presentation. Just only last question. You said that the oral...
Yes, that was, there are 2 companies now that, at least that we have availability in the United States that provide a mask that can fit on those now, but they're relatively new over the last
4 years and no side effects.
Yeah. But some of the centers that are using that are still seeing some breakdown on the bridge of the nose depending on how it's secured on. So they're using an alternation where they're using some masks in the front, and that's worked out much better.
What about using sustained lung inflation when the baby is on CPAP? I think CPAP is good in maintaining the FRC, but not in creating the FRC, and the patient's effort are essential for creating an FRC, and that's why the bi-level CPAP proved to be more efficient than the classic CPAP. So why not to use sustained lung inflation in babies on CPAP? What do you think about this?
I think it's very interesting, and I agree with you. We only have one study out there that says anything, but the centers that use it really like it. They're just not really documenting it out there in the literature. I feel like in the United States at least, this type of mode is very new. And when we first got it in our NICU, I tried to help explain it as it's kind of like APRV, but we didn't use APRV at that point in time either, so they're like, I don't know what you're trying to say to me. So I think it's really the change and people getting used to having those 2 levels, and it's not pressure support, it's not BiPAP, it's not 5-level ventilation. So when we look at the names that we use within ventilation, I think people in their mind say this is too high of a support and I don't want that, and they don't think of it as you stated as sustained inflation or even a side breath. And there really needs to be some more literature, I think, on it, and really a change in thought process, because we're not all good at change overall. I think that's part of it. It's more of a practitioner hindrance than it is the equipment itself, but there's definitely a lot of promise with it.
Any more questions? Okay, thank you, Dr. Nathan. I have the pleasure now to present Dr. Muhammad